Foundations, and he is also working in the World Bank, and in some years, in the recent years, he worked in British Columbia in Vancouver, but now he returned back to Boston. And we are very pleased to have Professor Peter Freeman for a discussion with us. And I hope that you can, the students, prepare some maybe questions or maybe some arguments on the things about health financing internationally and also the future of UHC. But before we start, maybe Peter, can you have some highlights of your presentations? Because actually we have your video, yes.
Yeah.
And all students already watched the video. Okay, so please, if you have some highlights to be
okay.
Yes, please. That's yours.
I'll try to give a few key points. And first, let me say Selamat pagi semua. I know it's very early there where you are, so I appreciate you taking the time to join. Can you hear me okay?
Yes, we can.
Yes,
it's clear, sir. Thank you.
Okay, good. So I hope that all of you or most of you have had a chance to go through the material that was on the video. And I just want to emphasize a few key points. So the first key point is that we do have to acknowledge that with the experience of the global COVID-19 pandemic, there were some very significant and very unusual financial and economic stresses placed on all countries around the world. And this was not only the direct cost of the pandemic itself, but also very significant burdens that governments took on to mitigate or reduce the impacts of the pandemic on issues like business, employment, social welfare, and so on. And this created very large deficits in many countries around the world, both the lower and middle income countries and the upper income countries. Okay, that's one key point. So we could say that from around the end of 2022 or 2023, we probably should have seen the effects of those economic pressures start to be reduced or to start to disappear. But what instead we have seen since that time is further economic strains, especially on the lower and middle income countries around the world. And these are seen through the impacts of rising government debt and the government service on that debt that governments have to pay. And in my presentation, I quoted a number of somewhere between 30 and 65% of GDP that was going to pay for those costs. And also the slowdown that took place in global trade and exchange, which has been accelerating back recently, and inflation has been going down in the last year or two, which was one of the side effects of the COVID-19 response, but especially for the lower and middle income countries. And this is particularly visible in Africa, but it is also true in some of the other countries. And I know even today in Indonesia, there's a lot of discussion about the economic pressures on the country, the slowdown in growth, the rising debt that wasn't there before. So that's a second key point. We are not in any sense out of the difficulties that started during the pandemic. And this is very important for our health issues. Then in my presentation, I started to go into some of the definitions around universal health coverage. And I'm happy if we can discuss this a little further. But I think you can see that there has been some uncertainty in the way UHC has been defined, in particular, the distinction between universal coverage for all health needs. I just got a sign that says my language was not detected. Change language to English. Should I do that? Okay, I did that. And that in the transition from the global movement for UHC, which started in 2005, to the way that it was framed in the Sustainable Development Goals, there was a very important distinction made between universal health coverage for all health needs and universal health coverage for what were defined as essential health needs. And this distinction is very important, but the term essential was never defined in the global discussion. And it was left really to countries to decide what this meant. And in many countries, this is a very difficult thing to do politically, and so it hasn't been done. And so when we hear governments today saying we have achieved UHC, or we are our strategy is to achieve UHC, I think we have to ask the question, what do they really mean? What is their intention? And I think that if you look at the evidence that's been collected since 2015 through the regular, what are called the global monitoring reports of the World Bank and WHO, you can see that the progress towards UHC, even when it's defined in terms of a bundle of more essential services, has been slow. And there is a lot of reason to believe now that the goal by 2030 of achieving UHC is not easily going to be attained, even with a narrower definition of UHC as some bundle of essential services, and certainly not with the definition of UHC as all health needs. And this has also been the case for some of the financial risk protection goals around UHC. And I wanted to emphasize in my presentation, this is not only a problem facing the lower and middle income countries. The upper income countries are also struggling with the changes in health needs and the growing burden of meeting the needs of their populations. So while there are a few wealthy countries that are approaching something closer to a expanded definition of UHC, even many of the wealthy countries are struggling to do that and struggling to sustain it. And we can see that in Western Europe. We can see that in the US and Canada and so on. But more urgently for a country like Indonesia, where you have a very ambitious national health insurance scheme, which at least legally and on paper is intending to meet a very broad package of services and needs. This is really a struggle to deliver this, especially given the economic pressures. And even more concerning, what we are seeing is some evidence that the more attention that is being given to spending on high-level health needs, costly hospitalizations, and severe conditions of some diseases like cancer and heart disease, there is some evidence that this may be reducing the capacities to address some of the more basic health needs, which still remain significantly unmet. And what is interesting, I think, in Indonesia as well, is that your Minister of Health has been very vocal in recognizing that if Indonesia doesn't do more to prevent these more costly and serious conditions, the sustainability of health insurance and the voyage to UHC is going to be put into question. And of course, Professor Laksono has also led in developing some of the analysis of equity issues around the fact that we shouldn't be surprised by this, but perhaps we didn't fully understand it or anticipate it. When you provide coverage for high-level hospital-based services, the money flows to where the high-level hospitals are, and they tend to be not distributed very equally around the country and not equally accessible to people in the country. And so we see some of the potentially negative equity effects of the laudable effort to provide coverage for many health needs, but which needs to be accompanied by development of the supply side of the health system, not only financing those who can access those benefits. So let me stop there, I think. And as you all can see, if you read the news, if you read about the United Nations meeting in New York, which is going on right now, the UN General Assembly, we are seeing a retreat from some of the generosity of some of the rich countries to some degree, and we are seeing competition with new issues like climate change, which are threatening the future growth of spending on health in many countries. And so we're in a very challenging time. I don't have any easy answers to these problems. And I think we have been in periods of crisis like this before. We have been able to get through them and recover with new periods of growth and new periods of investment in human well-being. But right now, we're in one of the lower parts of this cycle, and we'll have to see how it turns out. So, Prof. Laksono, let me stop there.
Yeah.
I hope that's what you hoped I would do, and
Yes.
And turn it back to you.
Okay, thank you, Pak Peter. So, teman-teman mahasiswa ya, I think we have already heard about the things that Professor Firman mentioned. Jadi we can discuss in mixed bahasa because Pak Peter understand some bahasa.
Boleh.
Translate ya. You can bisa tanya dalam bahasa Inggris ya, atau Indonesia ya. Ya, tapi intinya memang kita dalam situasi yang berat ya after COVID-19 ini ya, dan ini tidak hanya di Indonesia tapi juga di banyak tempat di dunia ya, bahwa financing is more difficult at the moment ya. Oke, silahkan ya yang akan diskusi atau bertanya, monggo bisa pakai Zoom, pakai chat atau bisa pakai langsung raise hand ya. Silakan. Dari BPJS ya, ada? Silakan. Halo. Dari kelas SHI sekarang. Siapa? Wakilnya siapa? Masa nggak ada yang tanya? Nanti dari KPMAK yang
Don't
ada.
be shy.
Ya, jangan malu. Bahasa Indonesia boleh. Bahasa Indonesia. Silakan. Dari SHI, silakan. Siapa? Dari KPMAK? No? Oh. Oke, FF. Coba ya. Ada yang mau tanya nggak? Silakan. Atau saya tunjuk nih. Bahasa Indonesia boleh. Silakan.
Izin, Prof. Mungkin saya, Prof.
Ya, silakan. Pak Cucu, silakan.
Ya, mudah-mudahan agak nyambung dengan disampaikan oleh Pak Peter tadi ya, kaitan dengan bagaimana beban negara kita dalam memastikan aksesibilitas seperti itu ya. Dunia pembiayaan juga terus meningkat seperti itu. Kaitan dengan pembukaan akses yang saat ini tengah gencar dilakukan oleh pemerintah kaitan dengan pelayan perangkat JSU, KIA seperti itu. Mungkin Prof. Berman udah tahu, Prof ya. Nah, mungkin tanggapan Prof. Berman terkait hal ini seperti apa? Karena di daerah-daerah yang jauh dari Jawa mungkin masih memerlukan persiapan infrastruktur yang lain. Izin, Prof.
Ya, Pak Peter, can you understand the points? So, he asking about because we have the policy for expanding the catastrophic services like for cancer, radiology, stroke, and also uronephrologies, okay, to the remote areas. And that means for BPJS, it is like a dilemma. It will increase the claim of the catastrophic disease. Yeah. What is your maybe comments or maybe argument on this issue? Oh, yeah, you are muted, Pak Peter. You are muted.
Okay, yes. So sorry. I do think, obviously, if you expand the access to these higher level services, and BPJS is going to be paying for these services through the payment system that exists, this will increase the financial burden on BPJS significantly. To some degree, the size of this, or the pace of this increase, is going to be constrained by the supply side. What's available, how many providers, hospitals, beds, equipment are available. But as the policy is to expand the access to these services, there will be investment in the supply side, and this will increase the pressure on BPJS finances. And as Prof. Laksono has shown in some of his work, and others have shown, BPJS is currently running something of a deficit between the revenue that it collects and the spending. And so this deficit can get larger. Now, ultimately, you cannot run a large deficit for very long without someone paying the bill. Or the alternative, which is reducing the volume of services, making services less available, longer waiting times, and so on. So one of the cardinal rules in the development of health insurance is that you must try to equalize the revenue and the expenditure over time. In social health insurance, you don't have to make a profit, but you don't want to make a large loss that the government will have to make up or something else, and you can't do that for very long. What we often see in other countries when this happens is that they create some debt with the facilities. The hospitals borrow money to buy supplies and equipment or to pay for staff, and they expect to be paid back from the insurance claims, but the payback is not on time. And so they create a debt. And ultimately, this is not sustainable. Now, I think Prof. Laksono, he was also asking me about KIA also.
Yes, KIA, yes. Kesehatan Buana.
Yeah, so, one of the challenges is that right now in Indonesia, you are financing the complete package of healthcare through two very different channels. One is the health insurance channel, and one is the government funding channel, much of it through the health ministry, but also through the direct aid to the kabupaten, and also through the Ministry of Village Affairs and others. And so you have multiple funding channels from the government. And while BPJS does provide capitation payment to the primary care facilities, some of which is intended to pay for the KIA services, what BPJS provides is not enough to finance the full primary healthcare services. The studies that we recently did indicate that the BPJS financing of capitation may be only paying 10 or 20% of the primary healthcare costs. And so if you create more deficit in the hospital side of the BPJS budget, what is going to happen to the support for the primary healthcare? This is another thing to be concerned about. And so you have a complex financing structure with very complex incentives to the different actors. And I think there needs to be some very good work to be done to understand this better and to try to make it clear what are the priorities and why are those the priorities and how to achieve those priorities.
Oke, Pak Peter. Ya, jadi begitu ya Pak Cucu ya. Saya berusaha untuk membahas ini juga ya. Memang ini dilema untuk BPJS dan juga untuk pemerintah Indonesia ya. Ketika data selama 10 tahun itu memperlihatkan bahwa khususnya dengan data sampel 1% BPJS ya, itu klaim itu lebih banyak di Jawa dan di kota-kota besar ya untuk tadi KJSU ya, kanker jantung, stroke dan uronefrologi ya, uro ya. Kayak lebih baik lah, nggak begitu ya. Nah, itu ada sesuatu yang salah dalam hal ini, yaitu supply side tadi yang Pak Peter katakan. Ya, supply side kita selama 10 tahun itu seperti tidak terbangun ya Pak ya. Dan kompensasi juga belum berjalan. Ini ada dari teman di saya ada juga yang diskusi kompensasi, ternyata juga belum jalan ya. Jadi gap antara yang luar Jawa dan Jawa itu menjadi sangat besar ya. Nah, pada waktu saya di Kemenkes, saya juga sering diskusi dengan Pak Menteri mengenai hal ini ya. Dan Pak Menteri mengatakan ini tanggung jawab Kemenkes, Pak, untuk supply side tadi. Dan saya sebagai Menteri Kesehatan, Pak Bikes ngomong seperti ini, sampai dia bilang pakai, kalau nanti saya mati, ditanya malaikat di sana, ditanya, apa yang kamu kerjakan sewaktu jadi Menkes untuk mengatasi ketimpangan ini? Nah, dia jawab, ya saya harus berbuat sesuatu. Kalau enggak, saya akan menghadapi pertanggungjawaban yang berat sekali di akhirat ya. Nah, dan ini jadi komplikasi karena uang nggak ada. And you know Pak Peter ya, so most of the investment costs ya is financed by the World Bank and many like consortium of lenders ya. Tahu ya
Yeah.
Pak Peter ya?
Yeah.
Yeah.
But let's be clear. The World Bank is lending money to government of Indonesia, but it's lending. Government of Indonesia has to pay for this money. It's a loan. Like if I give you a loan to build your house, you build your house, you pay me back also, right?
Yes, that's right. Yeah. And it's a huge amount of money, and I think it's the biggest lending pinjaman terbesar nih Pak Cucu ya. Jadi ini dan ini jadi masalah politik juga karena sebagian orang mengatakan ini kan cuma orang beli alat ya. Tapi waktu itu diskusinya dengan beberapa orang yang anti tindakan ini ya, anti KJSU itu ya, dengan katakan tidak mungkin di Maluku Utara itu akan ada cat lab gitu Pak, misalnya Pak ya. Ya, karena SDM-nya kurang, PLN-nya naik turun, ya pokoknya banyak sekali alasan yang katakan tidak mungkin bisa. Nah, pada waktu debat seperti itu ya saya bilang, loh kalau begitu, mengingat Undang-Undang Dasar 45 yang diacu oleh Undang-Undang SDSN dan BPJS mengenai prinsip ekuitas ya, itu berarti semua prosedur pakai cat lab harusnya dicabut dari BPJS. Paham nggak Pak Susu ya? Logikanya kan sama gitu toh Pak. Kalau bayangin Pak di Sarjito di Yogyakarta, so in Sarjito, you know Pak Peter ya, in Sarjito we have about 6 cat lab machines. 6.
Okay.
And Maluku Utara, not Maluku, is nothing there.
Right.
Now it's becoming one, I think. Yes, sedang dibangun satu. Nah itu loh Pak Susu ya. Jadi ini problem besar Pak. Jadi Pak Menteri Kesehatan take risk dan dia tahu akan dibully banyak pihak ya tentang pinjam uang di Bank Dunia ini ya, dan ini jadi sampai sekarang pun masih menjadi isu ya. Dan juga tadi saya nggak tahu nih bagaimana kebijakan BPJS ya. Nah, karena kalau SDM harus sama dengan yang di Jakarta ya mungkin agak susah juga nih. Tapi ini masih menjadi isu nih. Ya, betul Pak Zu ya. Tapi ini kan ya kalau saya jadi BPJS ya saya juga akan mikir equity itu penting Pak. Karena kita Pancasilais Pak ya. Benar nggak? Ya, tetapi harus sama. Nah, makanya nanti ini kan, so this meeting is one of the series of meeting. You can follow Pak Peter about head financing.
Yeah.
Dan nanti akan ada semacam scenario planning untuk kedepannya. How we can go to the future, yes. Apakah APBN, nah ini banyak uncertainty-nya, ketidakpastiannya. Dan kita tahu ya, Ibu Sri Mulyani, she was like bullied by the netizen of Indonesia. It's so bad bullying, and then also some of the penjarahan, what you call it, like what is penjarahan in English? Penjarahan, you know, Pak?
I don't know that.
Penjara is like ransack, something like that. Yeah.
Okay.
Yeah.
Her house, you mean? Yes.
Yes, the house is. Yeah, it's the ransack.
Yes, I heard about that. Very unfortunate. Yes.
And one of the issue that she mentioned about how to increase the premium for BPJS.
Yes.
Either that you mentioned, Pak Peter, you mentioned that from the government side or the public side, because BPJS, not like in Thailand. In Thailand, the USC is funded most all by the government or by employees. Yes, okay. No PBPU. Tidak ada premi dari masyarakat. But in Indonesia, this is becoming problematic. The PBPU is paid by the community, okay, and they are middle class, and they speak very, very loudly. Betul nggak, Pak Cucu ya? Yang PBPU kan kelompok kelas menengah tuh Pak ya, ya, yang mereka sangat-sangat vokal. Begitu ada kenaikan pada waktu zamannya Pak Terawan, ingat nggak Pak? Pernah ada kenaikan tarif ya. Tapi kemudian DPR rapat dari jam 4 sore sampai jam 4 pagi, Pak. Itu kemudian dibatalkan. Ya ini yang jadi masalah besar, Pak. Jadi kita sebagai bangsa memang terjebak dalam situasi seperti ini. Tapi let's go to the future.
But, Prof. Laksono, I have to say, let me just say,
yes,
I don't think that these specific things, for example, providing the benefits, subsidizing the poor people to get the insurance, building up the supply side in the remote areas to increase access. None of this is wrong per se. The question is the balance between the ability to pay, the capacity, financial capacity of the system, and the development that's being done. And this is where I think the challenge comes, is that the system that was established is very ambitious in terms of its scope, but the capacity to sustain and finance it is not sufficient. It needed to be more in phases or in stages, right? So it's not that any of this is wrong. It's just that without the capacity to sustain it, it creates other problems. That's just one.
That's why the things that we have to look at the future, ini tentang private health insurance.
Yeah.
Okay. At the moment, many of the so-called middle or maybe upper class of Indonesians, they come and join the BPJS. Okay. And the evidence shows that most of the catastrophic claims is paid for them, not for the poor. The catastrophe. Right. Okay. Now the point is, where is the role of the private health insurance? Jadi ini, di mana peran dari askes swasta? Nah, ini yang jadi isu kunci. I will show you the data. Sorry, yes. Bisa data dari Mbak Vini bisa lihat nggak? Atau saya harus masuk nih?
Prof.
Ya, oke. Mbak Vini bisa buka nggak?
Saya share yang PPT ya, Prof.
Ya. So, Vini is she is a young lecturer in Gajah Mada. She is has like studying about or learning about private health insurance ya. Jadi ini ya Pak Juju ya. Jadi kita sudah saatnya itu membuat private health insurance itu menjadi lebih kalau kita sebut ya lebih sebagai mitra BPJS. Yes. This is like a safety valve ya, katup pengaman. So BPJS is very heated, Pak Peter ya. It's so like the tension or the pressure of claim is so big. So we have to have like a safety valve, yeah. And this is maybe private health insurance, yeah. And this is the problem because private health insurance is so low in terms of penetrations. It's less than 5%, about 4 to 5% of the funding. And only less than 1% of people who has private health insurance.
Yeah.
So this is ini Pak Cucu ya dan teman-teman BPJS ya. Memang BPJS berhasil ya untuk menarik tadi anggota, bagus sekali. Tapi masalahnya yang menengah ke atas pun kemudian tidak beli asuransi kesehatan, Pak, private. Jadi mereka bergantung pada BPJS. Bisa dipahami ya?
Now, I want to tell you about one of the experiences.
Yes.
In another country, this was in Chile, when they created a private health insurance option, and also Colombia in South America, they have done this. And but the key challenge they faced in Chile is they let the higher income people choose, pay into public insurance or pay into private insurance. So they left the public insurance and they went to the private insurance, but then the money that they were giving to the public insurance also left. So now the public insurance had to pay for the other people, but without the revenue. And this turned out to be a big mistake. So one way to manage this would be to identify a few, let's call them high-cost interventions that the public system cannot afford to pay for today. Allow private funding to come into play, but don't let the middle and upper class stop to pay for the public insurance, because you need that revenue to finance the public insurance. And this is where the difficult problem comes.
Yeah, okay. So this is one of the things that we will discuss in the future webinars. But there are some questions, Pak Peter.
Yeah.
Can you read in the...
I see the chat, yes.
In the chat, okay.
I see Sri Budiani.
Niketut Sri Budiani.
Yeah. So to what extent can the private sector contribute to UHC financing without compromising equity? So I do think the private sector can contribute to UHC financing. And one of the ways that this could be done would be to identify some services, some needs or benefits that for the moment the government system is unable to afford, unable to finance, but to have a well-regulated system for private financing that would at least protect people from fraud, from being cheated, given poor quality care, and so on. So many countries have both public and private insurance existing side by side, but the benefits covered by the two systems are different. Okay. I will also say that we need to be a little more understand some of the concepts around private financing. There are countries which provide social health insurance using private companies to deliver the health insurance. There are many examples of this in Western Europe. And in the United States also now, we also use private companies to do this. But in the United States, for political reasons, it was decided not to allow the government to compete in that market. This was at the time of the so-called Obamacare reforms. But if you look at Germany or Netherlands, you will see that very much regulated private insurance companies offer the same packages as the government insurance. And the argument in favor of that is that these private businesses might be more efficient than a single large government system. So there definitely is a role for the private sector in UHC financing. And the equity question is a very challenging one, because ultimately, if you have different people who are able to access different benefits, is it inequitable? Well, it is certainly not equal, but we may need to be practical about equity and think about how much equity we can afford and what would be the best things to pay for in the most equitable way. And I think that's the challenge facing many of the middle-income countries today. And I will tell you, this is not only the middle-income countries. I spent a number of years living and working in Canada, and the Canadian health system, which is a single pay, a universal coverage system with a government payment, although the payment is done at the provincial level, not at the national level. There are many services that are excluded from that system because the government cannot afford to finance them. So in Canada, if you need physical therapy, for example, it is not paid for by the social health insurance system in most cases. And also, out-of-pocket payment for drugs that are not administered in a hospital, those are not paid for by the public system. Well, how did they make these decisions? Well, they decided to cover some things and not to cover other things. And the private sector does these other things. Does it do it in a very equitable way? No, not necessarily. But at least it allows the government to do a more limited bundle of things in a very equitable way. So this is the trade-off. I see there's a... Yeah, go ahead, Pak.
Oke, thank you, Pak Peter. Jadi harus hati-hati ya. Tapi tetap ada peluang ya. There is a chance ya for private health insurance ya. Jadi komplementasinya itu apa? Bersama-sama itu jadi peluang. Tapi tetap ada problem inequity. Ya, ini harus kita lihat ya. Oke, ini ada pertanyaan dari Bu Kartika ya, Bu Kartika Widyasari, ya silakan. Resign. Oh, there's so many questions after one. Okay.
Thank you, Prof. Laksono, and I would like to ask some question to Professor Berman.
Sure.
So, previously in my experience, I have been working in a health financing division in a private hospital, but as we know, my hospital has faced a significant burden because, BPJS have failed in paying the reimbursement. So I would like to know your opinion about if hospitals should adjust their service package rates in line with BPJS reimbursement, or would you recommend alternative strategies for sustaining health services? Because, some patient in the ICU, they might need more costs compared to those undergo the care in the normal ward. So that's my question. And then maybe it's kind of new for me about health financing. So I would like to know about the difference between the health system in Indonesia and the ones that is going on in European health system like that. That's my question. Thank you.
Okay, that last one is a big one. So the question about the tariffs for private hospitals relative to government hospitals is a very important and a difficult question. As you know, the government hospitals, much of their costs are financed from the government budgets, right?
Yeah.
The construction costs, many of the capital investments, and in many cases, even the salaries of the workers in the hospital. And so the reimbursement or the payment rate to the government hospitals should be lower than to the private hospitals because another part of the government, not BPJS, is paying some of the cost. But what should be this difference? And what is the amount that is needed to incentivize the private hospitals to deliver the services? That is a difficult technical question, and it's going to be a difficult question with different answers in different places because the costs are very different. Now, one of the arguments in favor of the BPJS payment system is that it can control the costs of the private hospitals by by being the market maker, as we say. The social health insurance becomes the big payer, and everyone has to try to adhere to that. And that's an important argument because you don't want to let the private sector simply charge whatever they can for everything. But you also have to find the place where they're being paid enough that they want to have the patients come. Otherwise, they will place barriers in front of the patients and keep them from coming. They will not be available, they will have to wait, and so on. Or worse than that, you end up sometimes in some countries with a kind of corruption where the private hospitals get paid, under the table, sort of, which is illegal in some places, but it happens because people want to get those services. And we see this, in countries sometimes like China and so on. So this is a difficult problem. And I think that in Indonesia, it's still early days to know how to solve this problem because you have this structure with both government owned and operated and partially financed by budget hospitals and partially financed by health insurance, and then non-government hospitals, which are 100% financed either by charges to patients or by health insurance. I'll give you an example from the US and Canada, which is important. In the United States, hospitals are allowed to do what we call balance billing. So if you go to a hospital and your insurance company pays only 80% of what the hospital wants to charge you, the hospital can charge you the other 20%. In Canada, this is illegal. The hospital must accept the payment of the government health insurance, whether it's a government hospital or a private hospital. If it will not accept that payment fully, it cannot participate in the health insurance. And because in Canada, almost all the hospitalization cost is paid for by health insurance, you cannot have a private hospital if you don't participate, right? So there's a strong pressure on the hospital to do that. Now, you wanted to compare Indonesia with European countries. I know sometimes I'm a bit of a broken record on this, but the biggest difference, of course, is the amount of money that's available, okay? In Western European countries, you have spending, in the thousands of US dollars per capita per year for comprehensive benefit packages. Indonesia is only really probably at a level, maybe only 5% of that or something, depending on which country you're talking about. So that's a huge important fact. And you have to adjust. Ultimately, I believe you have to adjust the benefit package, the resources that are available, okay? And in European countries, you see a lot of different structures. You see some countries which have largely government-funded healthcare, like the United Kingdom or France, Germany, Netherlands, and some of the others. but they have a mix of roles of private insurers and private providers in those systems. And so there's no single model that is the perfect model everywhere. And I think that's one of the lessons we learn in comparative health systems research. Each model has its positive and negative effects. They are driven in part by history, they are driven in part by politics, and they're driven in part by what's feasible to do in any given time. So Indonesia embarked on a very ambitious journey. That's something to be proud of, I think. But you have many challenges that you have to solve.
Okay, thank you, Professor Berman.
Oke, dari memang Indonesia waktu menyusun undang-undang SISN, BPJS dan PPPP-nya ya, peraturan-peraturannya ya, itu memang ambisius ya. Jadi mungkin ya promise-nya besar sekali ya, tapi ini yang jadi masalah sekarang, tantangannya menjadi luar biasa berat ya. Tapi ya kita harus hadapi ya, that's fine. Oke, Ibu Adriana silakan, Bu Adriana. Oh, masih mute.
Ya, baik, terima kasih Prof.
Ya.
Izin menggunakan bahasa Indonesia.
Ya, silakan.
Ya, bisa. Coba.
Oh ya, thank you Mr.
Saya coba.
Ya, terkait dengan situasi COVID, itu akhirnya menyebabkan banyak pekerja yang kehilangan pekerjaan, sehingga akhirnya bertambahlah masyarakat yang miskin. Nah, kita tahu bahwa masyarakat miskin artinya kemampuan untuk membiayai hidupnya juga berkurang. Nah, pemerintah dalam hal ini tidak bisa, kemampuan daerah apalagi remote area kan agak susah, kebanyakan bergantung PAD juga kecil, kebanyakan bergantung pada dana pusat. Nah, tetapi kita tahu bahwa penyelenggaraan pemerintah itu tidak hanya kesehatan, tetapi ada juga dia harus menyelesaikan masalah lain, misalnya infrastruktur. Infrastruktur itu juga berpengaruh kepada akses masyarakat untuk ke sarana kesehatan.
Yes.
Nah, akhirnya pemerintah kemudian membuat suatu strategi, mungkin minta pendapat. Akhirnya kalau sebelumnya semua masyarakat ditanggung, tapi kemudian menjadi karena bebannya terlalu tinggi sampai dengan sekitar 40-an miliar setiap tahun, sehingga kemudian dibuat bahwa kategorinya tuh kemudian diturunkan menjadi kategori yang miskin ekstrim untuk dibiayai pemerintah. Sehingga ada yang masuk kategori miskin tetapi tidak ekstrim, kemudian ini juga menjadi beban dari BPJS karena tidak melanjutkan pembayaran iurannya, sehingga ada banyak tunggakan. Karena pemerintah pada posisi ya harus mengcover seluruh permasalahan yang ada di daerah. Nah, apakah strategi ini menurut Mr. Peter dalam hal ini pemerintah sudah bersikap adilkah atau bagaimana terkait dengan beban yang harus dipikul oleh suatu daerah? Terima kasih.
Yeah. Well, I think I understand your question. You know, I think that it is probably not very helpful to use terms like adil or equitable or so on as a single terminology. You know, there are degrees of fairness, keadilan, and so on. And we need to recognize that when resources are limited, we cannot necessarily right away achieve perfect keadilan or equity or whatever. We have to, you know, be seimbang. We have to balance different things, right? And then that becomes a question of what are those things and what do we consider positive progress? And then over time, we hope to increase that progress, right? And I think that's the way I like to think about this question, you know. So the fact that the government tried to provide the benefits to the extremely poor and the less poor, that's a positive thing. But the ability to do that in the more remote regions at the same level as in, you know, the big cities and so on, that's going to take some time. That's not something that happens right away. Even if you declare the promise, to deliver the promise is not the same thing, right? And so that's how I think about it. So I do think some of this was positive in its intention, but you are facing the challenges of now how to make it a reality. And when the reality cannot equal the ideal, then what should we do in the middle? That kind of question. That's my answer. I don't know if that's helpful or not, but
Okay. No. So I think
help
we'll
me
back
here,
to the
Lasono.
chat question. Still we have time. Yeah. 15 minutes more. It's okay for you, Pak Peter?
Yeah.
Yeah. Okay. Now we have the chat from Pak Ihwan Rudi Norianto. Can you read it, Pak Peter?
Let's see.
How could innovative strategies such as enhanced collaboration with the private sector be implemented to address long-term healthcare financing gaps in Indonesia?
I don't see that one. Can you say it again?
No. Okay. You don't see it?
No.
How could innovative strategies such as enhanced collaboration with the private sector be implemented to address long-term healthcare financing gaps in Indonesia?
Right. Okay. Well, so the question is, how could they be implemented? And I think that this, first of all, will require a recognition, probably a legal recognition, that the capacity of the national system is not sufficient to deliver all that's been promised. I recently published a paper with a colleague in Canada about the same thing, basically saying that right now there are gaps in Canada between what is being promised and what is being actually delivered. And in order to engage with the private sector to help fill these gaps, the government of Canada has to recognize that it needs some additional assistance to fill these gaps. So I do think there is a need for a recognition legally that there are gaps that need to be filled in innovative ways. And that's no small thing, given the fact that there's a lot of political history for why the system came about as it is today. Now, once that recognition is there, then you need a strong and transparent and accountable system to develop rules and regulations to work with the private sector on what will they work, what will be their responsibilities, what will be the quality measures and the equity measures and so on, and what will be the and how will that be made accountable, and then what will be their compensation also. So that's what I think has to happen, and that's a big job.
Yeah, and also he asked is from Pak Ikhwan about coordination of benefit concept
right
between BPJS and private insurance.
Yes,
but the implementation cannot be fully applied due to obstacles in mapping the BPJS benefit scheme, which is packet based, whereas private insurance has several benefit schemes such as charge and inner limit. Yeah, so it's not easy. What do you think?
I agree. It's not easy because the system that has been set up under BPJS is intended to be very comprehensive and universal, and so the implementation has not been fully feasible. So the question then becomes: you need to be able to find a way legally and administratively to acknowledge the gap and to make those changes. And this has been challenging given the legal structures. And I'm also, I have to say, from what I have seen and learned about things in Indonesia the last couple of years, you have a very centralized structure for this. It's all being done at the national level, and you're a very large, diverse country with many different environments. Very challenging to come up with a one-size-fits-all solution to such a large and diverse country. So maybe some degree of decentralization is needed also in this to allow innovation to develop in different places.
Yeah. Okay. So this is last question from the chat. Prof. Birman, thank you for the opportunity to pose a question. As we are aware, Indonesia BPJS National Health Insurance has been facing considerable annual deficit, and a range of policy measures have been proposed to mitigate this issue. In your expert opinion, what approaches would be the most effective in addressing these persistent deficits? Furthermore, could you provide examples from the US or other countries of how similar national health insurance challenges have been successfully managed?
Yeah. Okay. Well, I think that one approach to address, obviously, the deficits have two parts, the revenue and the cost. Okay. So the solution has to come from bringing those two things closer into balance. One approach would be to increase the revenue. And you've seen some of the issues around raising the premium contributions. This is very challenging in an economy like Indonesia's because the formal sector is still limited in size, and the tax system ability to raise taxes and generate more revenue is also limited by the structure of the economy and by the politics, which you're experiencing today, right? So we can see that problem. The other side of the equation is the cost side. And the way to address that is to potentially narrow some of the benefit package, reduce some of the things that are being covered, and probably there needs to be some kind of a public debate and consensus on what is affordable by the system and what should be paid from the public system and what is yet still perhaps too much. We see this process in the field of HTA, health technology assessment, when new drugs and procedures are being evaluated according to their cost effectiveness. But this is really not sufficient. This level of regulation, not sufficient to address the deficit. So I think we need to see movement on both sides, revenue and the cost benefit package side. In terms of other countries, again, I think the comparison with the United States is probably not the right comparison. We are seeing today a lot of discussion in the United States about reducing the cost side. We are seeing movement in our government to try to regulate drug prices more proactively. This is being opposed very energetically by the pharmaceutical companies. We will see if the government is successful in being able to do this. We have also seen new rules and regulations being put in place to try to make it a little more difficult for some of the lower income people to access government benefits. For example, saying they must be engaged in formal employment in order to be eligible for these benefits. These are efforts to reduce the cost side, and some of these efforts are not seen as very fair. And there's a very heated debate about this. In other countries, they have been able to limit a little bit more aggressively the compensation of the providers, the doctors and the specialists and so on. And so they have been able to introduce incentives to try to reduce the costs. But I think all countries, the richer countries, as well as the middle income countries, are going to have to do much more to try to prevent the development of the chronic disease condition that are going to cause high-cost services to create more deficits. So think about the efforts that are being put in place right now in Indonesia to introduce measures in primary health care to address some of the risk factors related to cardiovascular disease, diabetes, and other things. These are going to be very important activities, not only in middle-income countries, but also in wealthy countries, because all countries are experiencing challenges in being able to afford universal coverage.
Oke, thank you, Pak Peter. Jadi itu ya, saya kira semua negara di dunia itu menghadapi yang sama ya, untuk mempertahankan atau mencapai UHC ini tidak mudah. Negara kaya dan miskin juga mempunyai tantangan ya. Tentunya yang kaya lebih ringan mungkin ya. Dan seperti yang di Belanda itu, it's very interesting, Pak Peter. In Belanda, in the Netherlands, they changed to more private health insurance scheme from the social style or social perspective or ideology of healthcare. They're becoming a private health insurance. It's very, very interesting. Yeah. Okay.
But it's private health insurance that's very, very regulated to deliver a public package of benefit. Okay.
Yes.
So the argument there is that can a private business do this efficiently, more efficiently than a government bureaucracy? And this may be true in many places. We see this in Germany also. And people can choose. I want the same benefit from a private or a public company, this kind of thing.
So, Pak Peter, aligning our selaras dengan big change, perubahan besar ini, Pak.
Yeah.
Saya untuk Pak Peter di kalangan international expert, is there any like a movement to have like UHC revisited, something like that, melihat kembali UHC?
Yes, there is some movement. I will say that it is limited because some of the international organizations have continued to make and support very idealistic, ambitious concepts. But I think increasingly many of the experts in global health financing and systems recognize that these concepts they're beautiful concepts, but they're not practical in the short run. Okay. And we need to be more practical. So if you look at the recent report that came out about global health financing by 2050, you will see that they are calling for a focus on conditions that will be the most cost effective in reducing mortality by 50%. Okay. Now, these conditions do not include some of the things that people suffer from, that they may need medical care, but they are not going to be very efficient in reducing mortality by this target. So you just see different versions of the stepping back from the UHC is all healthcare that people need without financial hardship. Stepping back from that very ambitious, idealistic goal, we should keep it in mind for the long run, but we need to have a more practical approach for the short to medium term. Then the hard question becomes, what is that approach? So yes, I think this is being recognized.
Yes, dan itu tergantung konteks negara masing-masing ya, Pak Peter ya.
Yes.
Yes, and how the political situation ya.
Yeah.
Ini yang menarik di Indonesia dengan perubahan besar Pak Prabowo. Dia menempatkan equity juga, Pak. Dia membuka rumah sakit di daerah terpencil, Pak. Ya, sebagai salah satu bagian dari janji politik dia. Juga dia menghentikan Bu Sri Mulyani mengangkat Menteri Keuangan yang cenderung lebih agresif, lebih I don't know to say in English, but he looks like a cowboy in the bar.
Yeah.
Something like that, Pak Peter. You know that?
Yeah.
So still uncertainty in terms of Indonesian politics at the moment.
Yes, and I feel sympathy for the difficult challenges, right? And it's not just in Indonesia. There are other countries where I work where these issues are also very much there, even more so in the African countries, which have much lower income than Indonesia. So yeah.
Okay, Bu Sri Mulyani, one last question, yes?
Okay.
Bu Sri Wahyuni dari MOH ya? Bu Sri ada?
Iya, terima kasih Prof.
Yeah,
Prof Laksono, terima kasih udah diberi kesempatan. Thank you Prof Laksono and Professor Berman for this opportunity. We actually interested on the knowledge that the Netherlands applied the private insurance as a balance of the government program. So I'm interested to have a discussion on this matter. Allow me to just to confirm: is this a theoretical in an insurance program? Let me try to show the analysis. This is actually about confirming whether this analysis is correct. I'm currently on the doctoral program for the economic field, so maybe this is going to be helpful for me. Let me try to share. Okay. Is it showing?
Yeah.
Okay. This is my analysis. Try to make the Dutch program on the insurance I would like to see on the demand and supply side, whether this is correct or not, based on your expert. So let's see on the demand side, they are doing the intervention on creating universal demand, like a mandatory insurance, like you mentioned, offering citizens to purchase insurance. The government transform the potential demand of the entire population into effective demand. This dramatically broadens the demand base and resolve the adverse selection problem. And the second one, ensuring the affordable demand, like subsidiary, the government provides subsidized health allowance to low-income citizens. Graphically, this shift individual demand curves to the right, granting them the purchasing power to participate in the mandated market. And on the supply side, the Netherlands boosting supply efficiency, competition, allowing competition among private health insurance, encourage providers to become more efficient, innovative, and offer competitive premiums to attract demand. And the second one, regulating supplier behavior, open enrollment, like providers are prohibited from denying coverage to any consumers. And they are also must offer a minimum set of essential services, preventing them from only serving profitable markets. And the last one, encouraging long-term supply growth, where the system ensure stable, well-funded demand, sending clear market signal for future investment in training healthcare professionals and expanding facilities. So those supply-demand approaches, whether is it possible to be implemented in Indonesia? That is my question. Thank you so much, Professor Berman and Professor Laksono.
Yeah, thank you. I think that was a very good summary of some of the key elements in the Dutch system. As you probably know, the origins of some of this came from the work of a health economist, Alan Enthoven, who formulated this managed competition idea. So yeah, you've highlighted a number of key elements that were put in place and why they were seen to be mechanisms that would both improve efficiency as well as improve equity. And of course, the Netherlands has a much larger budget per capita than Indonesia does. So I think you couldn't simply duplicate the structure in Indonesia, but could you use some of the same principles and lessons for developing innovations? Yes, you could.
Thank you very much.
Okay, Pak Peter. Yes. Okay, I think time is up, no? And actually, this is again back to the issue. Ibu Sagina bisa dibuka ya untuk dan Bu Vini ya. So actually, this is one of the series of webinar for the sex webinars, and at the end of the series, we will have like a prediction. Yeah, Bu Sagina, can you? Yes. Okay. So the title is health financing in Indonesia, yesterday, now, and the future. Yes.
Okay.
Okay. So on the 22nd September, we have the history of health financing. It's not only for JKN but also for the public health financing. We have done it, and all of the material will be put in the website. Yes, recorded video. And then this is question number 2 about the current situations about international health financing trends, yeah, with you. And then the session number 3 next week, it will like a trend of the health financing from the government, especially for the APBN from the central government. And we try to have like a historical analysis on the issue, and then trying to have like what are the current political situations and the economic pressure on the APBN, because the 2026 budget may be already allocated in this period. Okay,
right.
But we can have like a projection on the central government. Okay, and then session number 4 is about the philanthropic funding. It's small, but I think it will be very important to be addressed, especially for BPJS, for the middle and low users or members. Yes. BPJS already has some policy, for example, inviting philanthropists to pay for the annual, the monthly premium payment for the people who are not able to pay, something like that. Okay, so we will discuss about this philanthropy. And then session number 5, this is actually a 2-day seminars in Kuala Lumpur. It is about how the social health insurance issue and the tax, like in Malaysia. You know, Pak Peter, in Malaysia, they are considering about moving from tax-based to mixed financing, including private health insurance and social health insurance. But actually in Malaysia, it's very interesting that in Malaysia, the private health insurance is so big. Almost 35% of Malaysians, they have private health insurance.
Yeah.
Compared to less than 1% in Indonesia.
Yeah.
It's so different. Yeah. Although in Malaysia, it is very interesting that the British legacy of National Health Service by tax is there, but people, they are not satisfied with the public services, so they buy private health insurance for private health services. Yes, in Malaysia, I think you know very well.
Yeah, very interesting. We did some work in Malaysia about 10, 12 years ago around some of the early ideas they had about health insurance, but at the time the politics was not very receptive. So
yes, so that's why this is again they try again to have like a social health insurance, but the fact that in Malaysia the private health insurance is becoming already large. Yeah. Okay, so that's why in this Kuala Lumpur meeting for today, it will be like a combination of private health insurance and social health insurance. And then lastly, in the seminar number 6, we have the prediction of the health financing in Indonesia for the future. So
good.
Funding resources from the government, central and the local, from the private health insurance, from philanthropy, and for overseas loan will be analyzed and then try to have like a scenario. And there is a study from economists about the 4 scenarios of BPJS. It's interesting to be addressed in this session number 6. So I think, but the point of view maybe is to lead for you, Pak Peter. But there is some videos on this. I will discuss with you, and hopefully maybe in the last seminar you can come again.
I would love that.
Yeah,
it's very interesting. Yeah,
about the prediction. Yeah, and we try to have like is it possible at 8 a.m.? 8 a.m. No problem. Because 7 a.m. maybe for some people is too early.
Yeah, 8 a.m. is okay. 8 a.m. is okay. Sure, fine.
Ya. Oke, dan ini ada satu dari Mbak Vivi nih, Mbak Vini coba lihat ya. Ini ada satu data yang mungkin dari teman-teman yang mahasiswa mau meneliti. Jadi data yang health financing, ya, comparative analysis internasional. Mbak Vini ada ya? Mungkin bisa dilihat dari tax ratio, public and private ya. Menarik ya. Silakan Mbak Vini.
Terima kasih Prof. Prof izin, ini yang tadi Prof ingin sampaikan dan juga sudah disampaikan oleh Pak Peter Berman. Ini ada tentang pembiayaan, sumber-sumber pembiayaan baik dari pemerintah, bisa dilihat pada beberapa negara. Ini Indonesia, tadi juga sudah disampaikan Pak Peter bahwa tax revenue Indonesia kita lihat tahun 2023 masih sekitar 12%. Tadi juga disampaikan oleh Prof, ini angkanya masih rendah, dan kalau melihat rasionya juga ini tax itu Indonesia negatif 0,2 persen poin, dan kalau dilihat tadi OOP-nya Netherlands tadi juga kasusnya sangat walaupun private, dikelola oleh private, tetapi OOP-nya rendah seperti Pak Peter sampaikan bahwa dia terregulasi dengan baik. Kita bisa lihat ini GDP-nya, apakah Indonesia mau seperti Belanda, ini GDP-nya Netherlands di atas 10%, sedangkan ini Indonesia pembelanjaan kesehatannya hanya sekitar 2% lebih, tidak sampai 4%, dan ini menurun di tahun 2022. Jadi memang seperti di Jerman, tadi juga Pak Peter bilang, walaupun ada SHI, tapi private health insurance-nya diregulatif juga seperti di Belanda, diregulasi dengan sangat kuat, dan juga government mereka 10-11% lebih, hampir 12% untuk membiayai kesehatan. Ini untuk Indonesia trennya dari 2000 sampai 2022 bahwa government Indonesia ini semakin meningkat dari 29% terus meningkat hingga 51% ini karena ada juga SHI di sini, ada Social Health Insurance di Indonesia, dan namun di Indonesia masih banyak private out of pocket-nya masih tinggi. Dilihat yang warna kuning masih cukup ada 33% di tahun 2022. Dan kalau kita lihat SH ini adalah Social Health Insurance-nya. Kemudian yang coklat paling atas itu adalah Private Health Insurance. Jadi memang, sedangkan ini untuk Jerman, tadi Pak Peter juga, Jerman ini walaupun dia punya SHI-nya ini yang warna hijau 68%, tetapi di dalam SHI itu juga ada compulsory health insurance, private health insurance. Jadi ada sekitar 6% di Jerman yang dia bisa mensubstitusi dari SHI untuk masyarakat yang lebih memilih private tadi, tetapi betul-betul diregulasi private health insurance-nya. Kemudian ini di Jepang kita lihat bahwa publik itu 85%, tetapi walaupun dia ada private health insurance-nya sangat kecil, tetapi out of pocket mereka dapat dilihat ini kecil sekali, 11%, yang warna kuning. Kalau di Jerman tadi juga outnya 10%-an, sama seperti di Belanda. Di Belanda juga 10%-an out of pocket-nya. Dan di Belanda ini menarik, tadi selain dia ada paling banyak 51% adalah compulsory private health insurance. Jadi dia di sini private, tetapi dia diwajibkan. Kemudian dia juga ada SHI. Di sini dia SHI ini lebih kepada tadi private yang diwajibkan, dan dia juga ada yang memilih ke perusahaan asuransi swasta. Kemudian untuk voluntary health dia ada sekitar 5 untuk pembiayaannya. Ini adalah sumber pembiayaan kesehatan dari berbagai sumber yang ada di negara tersebut. Nah, ini referensinya yang tadi Pak Peter sudah menceritakan banyak sekali bagaimana banyak faktor setelah pandemi, dan juga tadi banyak bantuan-bantuan pada negara-negara yang hilang juga. Mungkin Bapak Ibu bisa membaca di sini, sangat lengkap sekali informasinya pembiayaan setelah pandemi. Mungkin demikian, Prof.
Ya, terima kasih. Ya, saya kira ini sebagai penutup ya. Jadi teman-teman mahasiswa kalau mau penelitian S2 pakai data sekunder, dari data itu udah banyak sekali yang bisa kita teliti ya. Silahkan Anda lakukan, dan sekali lagi bahwa pengembangan ke depan itu seperti Pak Peter katakan ya, itu memang tantangannya berat ya. Tapi kita harus menganalisisnya. Jangan sampai tantangan itu dimasukkan ke bawah laci atau bawah karpet, kita nggak lihat, tapi nanti bisa jadi bom waktu ya. Mari kita lihat apa yang bisa kita lakukan, dan kita tetap optimis untuk menuju Indonesia yang lebih baik lagi. Oke, thank you Pak Peter for everything you have presented and discussed with us. Terima kasih sekali, matur nuwun, dan sampai ketemu lagi pada pertemuan berikutnya. See you again. Bye-bye. Terima kasih semuanya.
Thank you, Prof.
Peter dan Prof. Laksono.
Thank you, bro.
Thank you very much. Yes.
Thank you very much.
Thank you.
Thank you.
Thank you
Okay.
so much.
Okay. Be well. Okay.
Okay.